COVID-19 Ministerial Advisory Committee Chairperson, Professor Barry Shube, is hopeful that the vaccines procured by South Africa will be effective against the variant first discovered in India. It's after 4 cases of that strain were recently discovered in the country. Shube says studies are being conducted to determine the efficacy of our vaccines as well as the new variant's transmission rate. South Africa has procured 41 million doses of Johnson & Johnson and Pfizer vaccines collectively.
The kind of bottom line answer is we don't have definitive proof. It hasn't been as yet tested against the B1617, the one from India yet. However, there has been studies in India where they looked at, first of all, people that have recovered from infection, and also looking at a vaccine made in India by a biotech company called Bharat, which uses, I guess, a first-generation technology. In other words, using one of the original strains to make the vaccine. And with both of these instances, the recovery as well as this vaccine worked pretty well against the variant. So I think we can extrapolate that our vaccines, both the Johnson & Johnson and the Pfizer, will in all probability work also pretty well against the new 617 variant. I think we're fairly confident that there will be good vaccine efficacy.
New daily COVID-19 cases are rising in South Africa. Infections have been hovering around the 2,000 mark for the past few days now. It's still not clear if this signals the start of the third wave of the pandemic. Now, recent metrics in provinces including Gauteng show a worrying uptick in coronavirus cases, with the vaccine drive yet to be open to the public. For more on this, we're joined by Wits University Vaccinology Professor Shabir Madhi. Professor Madhi, good evening to you, and thank you so much for your time tonight. Firstly, just on the issue of the discovery of new variants in South Africa and the concerns that many have where travel is concerned, do you think that there is a need right now to tighten the travel restrictions at all? Professor Madhi, I think you may be muted. If you can just check that button on the bottom of your screen for me. All right. I don't think that he can hear me quite clearly. Apologies for that. We'll try and bring him back up on the line. While staying with this story, Professor Barry Shube of the Ministerial Advisory Committee adding that there's no need for a blanket border closure and says that the restrictions put in place should be enough to protect the country.
This is an awkward one because basically a travel ban does impact on the economy, and this is something we need to protect, particularly we want to get our fragile economy going again. So it's really a balance. The ideal, of course, would be to close borders, but I think we also need to take into account economic considerations. So I think certainly restrictions and monitoring need to go on at borders. In other words, that travellers would need to kind of prove that they have been, that they are negative, that they are test negative, or that they've been vaccinated. And there needs to be quarantine provisions. So that, of course, goes without saying. But a complete closure of the border is quite a drastic step. And I think at the moment it probably is not warranted.
All right, so at least part of my question has been answered there by Professor Barry Shube. But let me bring in Professor Shabir Madhi of Wits University into the conversation. Professor Madhi, as I was asking you earlier, do you share the sentiment of the Ministerial Advisory Committee that the restrictions in place right now around travel are sufficient in protecting the country?
Yes, certainly so. I don't think that placing a restriction on travel of people that have been in India is going to make much of a difference. With regard to the trajectory of the COVID-19 in South Africa, the variant in India is somewhat similar in some aspects to the variant that dominates in South Africa. And at the end of the day, the biggest threat that faces us in South Africa is an unvaccinated population with ongoing transmission of the B1351 variant, rather than any impact of having other imported variants.
Professor Maddy, I'm sure you would have seen the research coming out of the CDC in the US around coronavirus also now being an airborne disease, and perhaps your own reflections of this admission, at least on the part of the CDC, and if it changes at all how we respond to the protocols to try and reduce the spread of COVID-19.
Well, the whole issue of the virus being an airborne transmission is nothing new. In fact, there was an article that colleagues and myself wrote about 11 months ago in the Daily Maverick, which made a strong case as to why we believed that it was airborne transmission, as well as what sort of measures needed to be put into place to minimize the risk of infection by individuals. So the fact that the CDC has suddenly gotten a wake-up call, seemingly, that this is a virus that largely transmits to airborne transmission, is neither here nor there in terms of what we need to be doing in the country. Avoiding mass gatherings, ensuring good ventilation, ensuring physical distancing between people is exactly the type of measures that you need to prevent infection for a virus that is transmitted mainly through the airborne route.
As we approach the winter months and we're already seeing these early warning signs that we could well begin entering our third wave, is there anything more that we can or need to be doing in this moment?
Now, the two most important things to do, and just to re-emphasize, is that at all costs, we need to avoid mass gatherings, especially mass gatherings in indoor spaces and poorly ventilated indoor spaces. And another major thing we need to do is ensure that we get vaccines into the arms of those individuals that are at highest risk of developing severe COVID. Those are the only two things that is really within our grasp to make an impact, to minimize hospitalizations and deaths from COVID-19 as we move into the third wave.
As scientists in this field, Professor Maddy, what have you begun to understand about what drives the infection rate up? Because we've seen this point in South Africa where the infections came down and they've been somewhat at very low numbers, and suddenly they're beginning to pick up again, and they're not necessarily being informed by mass traveling as we were anticipating over Easter. And so what really drives up these infections?
So there's possibly two different components. There's the virus itself, and then there's human behavior. And currently what we're experiencing in South Africa, perhaps more likely, is related to human behavior, in that people are more likely to start gathering indoors in poorly ventilated spaces as we head into the cooler months of the year. Coupled with that was some level of gatherings that occurred during the vacation period over the Easter break. But another component to it, which hasn't been a case as yet, that's been identified in South Africa, but certainly was one of the reasons why we had such a massive second wave, was where the virus undergoes mutations and becomes more adept in terms of transmitting between people and resulting in people developing more severe disease. So right now, the variant that's been dominating in South Africa seems to be the same as what we experienced in the second wave. So those are the two major factors. It's really human behavior coupled with what the type of mutations that the virus might undergo. Right now in South Africa, I think it's more function of human behavior, and in particular, again, unfortunately related to issues surrounding mass gatherings.
Do you have any concerns about the discovery of these two variants that were first discovered in the UK and India being present in South Africa?
Well, it is concerning that they're present in South Africa, but I don't think it's going to make a meaningful difference in terms of the trajectory of the pandemic. The variant from India, as an example, she has the same mutation known as the EEC mutation that's present in a South African variant, which makes the virus relatively resistant to antibody that's induced by vaccines, as well as bypass infection from ancestry infection. In addition to which, there's an additional mutation in a variant from India, which basically possibly makes it a virus a bit more transmissible. In contrast, the B117 variant from the UK is a virus that still remains sensitive to the effect of vaccines, but at the same time is much more virulent in that it causes more severe disease and much more transmissible. But again, I think the important issue in South Africa is that there's been a huge amount of population immunity that's built up over the course of the past two waves, with probably close to 50% of people in South Africa having been infected, between 40 and 50% already, and that would confer some level of protection, at least in protecting against severe disease, if not reinfection.
Most people right now would have their eyes set on getting the vaccines, and hopefully that vaccine drive will start on the 17th, as has been promised by government. But in the absence of that happening, what are the kind of preparations that also need to be put in place alongside those plans for vaccinations? I mean, are we supposed to be seeing the same scenes that we saw last year when government was setting up field hospitals? How are we supposed to know and gauge if in fact we're ready for the kind of peak that we had last year, or will it simply never be at that level again?
Yeah, firstly, I don't think that starting a vaccination program later than the 17th of May is negotiable. That should be a complete non-negotiable. We've delayed implementation of the vaccine program for way too long in South Africa, and unfortunately, because of us delaying it, we are going to suffer a death as well as severe disease during the course of the third wave. Starting the vaccine program on the 17th of May is going to be a bit too late to prevent the consequences of the third wave. That being said, what needs to happen is that we need to ensure adequate oxygen supply. We need to ensure adequate bed capacity. We need to ensure a motivated healthcare force that is going to be able to cope with the increase in cases of COVID-19. But I also remain optimistic that the third wave probably is going to be less severe than what we experienced the first and second time around, especially if the virus doesn't undergo further mutations. Because like I mentioned, there's been significant amount of infection that's taken place already, which probably is going to confer some degree of protection against severe disease and deaths from COVID-19 when people are infected.
Professor Madi, just before I let you go, at which point will we be in the third wave, effectively, of infections?
Yeah, again, unfortunately, extremely difficult to predict. Depends largely on human behavior. My estimate is we're probably going to see what we call a positivity rate, the percentage of people that are testing positive, increase above 10%, which is sort of a threshold where we would say the next wave has started. And that probably will occur within the space of the next 2 to 3 weeks.
Professor Shabir Madi, he's with the University of the Witwatersrand. Thank you so much for your time tonight.